Hello, everyone. I'm excited to do this in-service training on the new Termination of Resuscitation protocol. Now, yeah, we do have one, but it's not very specific. This should give you a little more guidance instead of, oh, let's just work them on scene 20 minutes and then call for orders to terminate. I do want to remind you that I do say a lot of things that's not necessarily included in the slides. So please turn your sound on and listen to me. I know it's painful, but just work with me the next, 30 or 40 so minutes, please. So I don't know if any of you have ever seen Travelers. It is a show where people die, and then these people from the future, they kind of go back in time. They travel back in time. They inhabit their body with the purpose of saving their lives or saving the world. Well, this is not the Travelers. So generally, we either save a person or the person dies. It would be nice if someone traveled from the future to redeem all of humanity, but that's just not the case. So these are actual human beings that we're dealing with. And we can kind of, portend their outcome. We can make good, educated guesses, not really guesses, but inferences based on scientific data and determine the likelihood of whether or not that person is going to survive. So why do this? What are our goals in developing a termination resuscitation protocol to begin with? Well, one, we reduce the burden on the family. How do we do that? Well, a lot of times all the family sees is us run in, treat the patient, load them up, and take them to the hospital. Many times we get to the hospital and the family has no idea what's going on. One, because maybe we didn't communicate, or two, maybe because they didn't see the full scope of what we were doing for that patient. So they may have been mistakenly under the impression that the patient might have survived. So then they get told at the hospital that they didn't, and they don't know what happened in between. It's also burdensome on the family for them to leave their place of residence, get in the car, go to the hospital, and then have to deal with it from there. It's much easier to deal with it in their home for most people. It also reduces the burden on the hospital. So, COVID, this is kind of timely for COVID, one, and then two, for us because it's a protocol that we need. It's better than the one that we have that we sometimes follow, that we sometimes don't, and we're having training on it. But especially for during COVID time, we reduce the risk on ourselves because we're resuscitating the patient in a more open, aerated area with better ventilation instead of being in the back of a concealed container, which is our ambulance. And we're lessening the risk that we impose on hospital staff. So yeah, we're still imposing risk on ourselves, but overall we're being better stewards in the healthcare system. We're improving safety, EMS safety. Now, transporting patients' lights and sirens are deleterious. We know this. This has been one of our major initiatives. It's just really not safe to transport a patient unrestrained, lights and sirens, especially for the provider in the back. Now, you might say, well, we have the Lucas, we can perform quality compressions using mechanical CPR device, but I think that the overall resuscitation is hindered. The dynamics of the resuscitation, the flow, are hindered by being in the back of an ambulance trying to hold on, focusing your mind and your balance on not getting thrown around, as opposed to a place that is where you're on firm ground and your sole priority is not to get the patient to the hospital, is to work on resuscitating that patient. And you have more people around you to help you than you can generally safely fit in the back of an ambulance. Last but not least, our goal is to prevent the termination of the lucky survivor or lucky survivors. So we know that we can work someone for 20 minutes on scene and call them. But had we gone 20 more minutes, is there a chance that that person might have survived if we just went on a bit longer? And there are cases of this. There are cases of patients with prolonged downtime, 60 minutes. There's even cases of patients that have been in cardiac arrest for 90 minutes or longer that have survived to be neurologically intact. Our current protocol as it sits will not catch these patients, and that is unfortunate. And I think that our new protocol will. This is endorsed by the NAEMSP, the National Association of EMS Physicians. They put out a position statement for all the reasons that we have previously discussed. Who does this not apply to? Well, clearly it does not apply to the obviously dead, okay? The ones that you're familiar with that have lividity, rigor, venous pooling, damage or destruction of the body that's incompatible with life, or if they have a DNR. Now, what does damage or what does incompatible with life mean? Does it mean a gunshot wound to the head? Does it mean someone whose abdominal contents are flayed open? It actually does not. Typically, incompatible with life means incinerated, not just severe burns, but meaning that you cannot recognize the person anymore. It would be like third-degree burns to the entire body. All right. Also, hemicorpectomy or decapitation, those are injuries incompatible with life. Just because the person looks dead, or it looks like they might have injuries incompatible with life to you, that doesn't necessarily fit the legal definition of incompatible with life. Yeah, lividity, rigor mortis, venous pooling, all that stuff applies. But there are patients that can look dead and not be dead. This happens quite frequently. There was a case in the northern part of the United States where I think they went out on a hypothermic patient. They called the coroner. The person looked dead. They didn't do a thorough assessment. And other people get there and realize that the patient's breathing, however, very slowly. We do not want that to happen. So when you're calling the coroner, when you're saying that someone has obvious signs of death, be very darn sure that they are dead. Now, it also doesn't necessarily apply to someone with a DNR, an EMS DNR, or a MOST form. And I've had a lot of questions about a DNR. Can I pace patients with a DNR? Can I manage the airway of a patient with DNR? There are some key phrases in this, and it's in the first paragraph. In the second sentence, it says, hereby direct that in the event of my cardiac or respiratory arrest, that this do not resuscitate order be honored. In the event of my cardiac or respiratory arrest. So that doesn't mean that we honor this or that we just let people die and then call the coroner. It means that we do everything that we normally would unless they're in cardiac or respiratory arrest. Now, we have to balance this with ethical obligations as well. I know a service that's very close to us that still intubates patients with DNRs. If I had a DNR, I probably would not want to be intubated. Now, that's something you can discuss with the family beforehand, before you transport them, and, say what would they want. And, just assist their ventilations with a BVM until you get to the hospital. But there are some patients that have DNR orders that have, let's say they would go suddenly into the third-degree heart block. And if they had a pacemaker and they had a good quality of life beforehand, all they need is a pacemaker and they could return to a normal status. Now, clearly, they're not going to be better than they were before. You can't fix somebody previous to what they are generally at baseline, but You can give them some more time with their family, and they might have the same quality of life that they had beforehand. So we still treat patients, and if you're ever not sure about what you should do ethically, legally, and you're in this situation, call medical control and consult them. These are also exceptions to this protocol. Children less than 18 years of age, we are still going to transport them. We're not terminating them just yet. It's could be difficult for the family. It could be difficult for us to terminate children after we've worked hard to resuscitate them. There's a psychological aspect on the level of the provider that we have to take into consideration right now. Now, it's not, it might be something we do in the future, but as of right now, we're defining children, anyone less than 18 years old. We're going to resuscitate them. We're still going to, perform high-performance CPR for 20 minutes on scene and then transport, but we're not going to terminate them. Hypothermic patients, there's a reason that therapeutic hypothermia exists, and it was extrapolated from hypothermic patients that were in cardiac arrest for a long time and that survived after they were rewarmed. Pregnant women greater than 20 weeks gestation, or they got a gravid uterus. They have a palpable uterine fundus, at least at the level of their umbilicus. These patients we're going to transport because even if they can't save the mother, they might be able to save the child with an emergency cesarean, an emergent C-section. So we still want to give at least the child the best chance of survival, so we're going to transport them rapidly. And, in our regular protocol, that's not a patient that we would have to resuscitate for 20 minutes on scene. That's a patient we could transport rapidly, but we still want to, try to tilt them on their left or manually displace the uterus and perform high-quality CPR. And then those with obvious signs of death or with a DNR or most form. So if we do not get ROSC in the field, that patient is 25, nearly 26 times more likely to die than if we were to get ROSC. So there is something magical, not really magical, but something that we should take into consideration. If we do not get a pulse back before we load that patient and head to the hospital, their chances of surviving neurologically intact are almost nil. So who are the survivors? We have to ask ourselves this. When we resuscitate a patient, who is most likely to survive? Because it helps us determine how long we should resuscitate them for. There are different metrics for determining survival, and our protocol encompasses all of these. Okay? Their downtime we have to take into account. The rhythm, is it shockable? Is it not shockable? End-tidal CO2, high or low? Is it getting lower? Is it getting higher? Was it witnessed or was it unwitnessed? Did the person clutch their chest and was 911 called immediately? Or did they come into the room and find them not breathing and without a pulse? And did they start CPR before we got there? So when we're looking at downtime, the likelihood of surviving based solely on downtime, you can see that the longer that they are down, the greater their chance of not surviving is. Bonin et al. Did a study showing that 0.6%, there was a 0.6% survival rate in patients who did not achieve ROSC within 25 minutes of paramedic arrival. So who are the survivors? Well, it's those with a witnessed arrest. So somebody witnessed the arrest, they started CPR, and they were found in a shockable rhythm. We know this. And in our protocol, these are patients that we're going to go a bit longer than the current 20 minutes. Opals was a study, a large study where they looked at data from the ROC Consortium, which is this large group of EMS providers that all band together to do research. And they split the criteria for survival and no survival between ALS and BLS. And the BLS is in the black letters. The ones... BLS criteria for terminating was unwitnessed by EMS. They didn't have an AED or shock, so not a shockable rhythm. And then there was no ROSC. They didn't get a pulse back. The ALS criteria, in addition to the BLS, was it was unwitnessed by a bystander, and there was no bystander CPR. Now, I just want to say, opals, if you actually Google that, you'll come up with these shiny rock things, and it's pretty neat, I guess, if you like collecting that stuff. My wife would like this. So, and then a lot of other articles looked at that. So there was this initial article, this initial study, and then it was validated or verified by other studies, and they found the rule to be 100%. And, the Sasson et al., they did a retrospective look at 2,592 patients. And those that met the BLS criteria, only 0.2, so 0.2% survived to be discharged. And in a lot of patients that met the ALS criteria, nobody survived. So BLS is pretty good. The ALS, in addition to the BLS, is really good. However, we know that just because someone has this criteria, we've had patients survived, right, that met all of this criteria. So it can happen. We know that patients do survive, and here's a study looking at this, looking at the BLS criteria. 4 patients, just 4 out of 776. That seems like a lot, right? But when you're looking at it in the terms of a person, an actual human being getting to leave the hospital and go back to be with their family, a number of 1, just an anecdote, right? Just an anecdotal case means a lot to that one person. And we're also going to be using end-tidal CO2 to predict whether or not someone, or to predict their likelihood of survival. So just to reiterate, we're using all of these things in combination. We're not just using one metric. But in this study by Eckstein, patients that achieved ROSC had an initial end-tidal CO2 of around 27.5. Patients that did not achieve ROSC had an initial end-tidal of around 15. So an absolute difference of about 10 or 12. Then they look further at variables that were associated with that person getting ROSC. So if it was witnessed, so the variables that were associated with achieving ROSC were a witnessed arrest, initial end-tidal CO2 greater than 10, and an end-tidal CO2 that dropped less than 25% during resuscitation. So you had an end-tidal greater than 10, and that end-tidal CO2 dropped less than a quarter of the initial end-tidal CO2 during resuscitation. This is one of the reasons we are so set on getting end-tidal CO2 early, because not only does it ensure that you're actually ventilating the patient, and not only can it help you determine if that patient has a pulse, but it can also help you pretend or prognosticate that person's chances of surviving the arrest. And in the future, going forward, after this training, you will require end-tidal CO2 to be able to terminate a patient. So let's imagine you've got this initial end-tidal CO2, and it's steadily increasing upward. If it keeps going up as you're working the patient, that is favorable, because theoretically, if you are doing good CPR and the end tidal keeps going up, that means that the patient has cellular function. And end tidal CO2 is a reflection of perfusion to the lungs, and therefore it's also a reflection of perfusion to the brain. So an increasing end tidal CO2 is favorable. The converse is also true. A decreasing end tidal CO2 throughout the length of the resuscitation is unfavorable. So if it goes from 20 to 15 and then it goes to 10, that's decreasing greater than 25%, and that is unfavorable. But there's a caveat. We also have to make sure that our CPR quality is staying consistent. So we need someone with eyes on that person performing CPR, and honestly, that should be the job of everyone on the resuscitation. If you see someone leaning on the chest, not allowing full recoil, not doing adequate depth, and not compressing at the recommended rate of 110, you should chime in. You should say something, because poor CPR can cause the end tidal CO2 to drop. Now, we understand that that's a possibility. And we wouldn't want to terminate someone because the end tidal CO2 is dropping as a result of poor quality or low quality CPR. That's why we use multiple metrics to determine whether or not someone will survive. So this is the protocol, or a section of the protocol. And you can see that it's a little complicated, right? So we separate it between medical and traumatic. There's a special section for traumatic cardiac arrest, or traumatic arrest with penetrating trauma, because those patients, penetrating trauma, generally have higher survival rates if you get them to a trauma center compared to those with blunt trauma. If it's someone with blunt trauma, we do the same as if it was a medical arrest. And then, if it's medical or blunt trauma, where we split it between the cardiac rhythms, whether it's PA with a rate greater than 40, or VFib and pulseless VTAC, or asystole or PA with a rate less than 40. Now, for the PA greater than 40 or pulseless VTAC, I'll go back so you can see that. PA with a rate greater than 40, or VFib and pulseless VTAC. We resuscitate them for a minimum, not of 20 minutes, but of 60 minutes from the time it is dispatched. So if you are deep into the resuscitation and it's clear that this patient is not going to survive, you can get the time that it was dispatched. In addition to that, you also have to have a minimum of 30 minutes of CPR. So I don't think that we'll ever have to use the minimum of 30 minutes of CPR, because technically if you work them a minimum of 60 minutes from the time of dispatch, you should have been providing at least 30 minutes of CPR. But there might be occasions, possibly, where it was dispatched and for some reason it took you more than 30 minutes to get there. If that's the case, then you're going to have to go past 60 minutes to provide a minimum of 30 minutes of CPR. Now, this includes refractory or recurrent VFib. And I understand this is a little confusing. What if they have an initial VFib and then they don't have VFib after the first shock and you never get it again? Or what if they're in VFib, then they go into PEA, then they go back into VFib? This includes those cases, the refractory or recurrent VFib or VT. They're waxing and waning in and out of VFib, or they're refractory to all defibrillations. It does not include the one that is in VFib. You get there, you defibrillate, and then they go to asystole or PA, and they never go back into VFib. We can't include every possible scenario in this. So you're going to have to rely on your experienced clinical gestalt and medical control. For asystole or PEA less than 40, it's a little more straightforward. All you have to do is 20 minutes total. 20 minutes total. If they're in asystole when you get there, or PEA less than 40 and it doesn't go above 40, well then just work them for 20 minutes. It's kind of like our current protocol. This one does not require medical control authorization. This one does. These are typically patients that you would expect to survive. And sometimes if you went a little longer, they might survive. So that is why these require med control authorization, and it's less burdensome on you because it is difficult to terminate someone in VFib or VTAC. Asystole or PA less than 40, a little more straightforward. In all of this, not everything is black or white. It's hard to assign black or white categories to prognosticating patients in cardiac arrest. We have done our best to ensure that you have all the tools you need to make that decision. But if you ever get to the point where you're not sure what to do, pick up the phone and call the hospital and talk to a physician. All right? It is that easy. If you're not sure what to do, just pick up the phone. You do not have to make this decision in a vacuum or in a silo. You don't have to make it by yourself or even with your team. If your team can't decide on the proper course, then pick up the phone and call medical control. Now, in addition to the aforementioned rhythm and time requirements, they can't have a pulse, clearly. They can't be breathing, clearly. The end-tidal CO2 has to be less than 20. And I, for one, would like to see it decreasing, like we talked about, more than 25% of the initial. All right, just for my own peace of mind. If it's 22 and it's staying at 22, you can't terminate. They can't have neurological function. What does this mean? It means they're not lacrimating, they're not crying, they're not swallowing, they're not gasping. They're not moving their arms. We have patients here recently with CPR-induced consciousness. And everyone on the scene has to agree that it is appropriate to discontinue the resuscitation. If the patient lacks any of these, and if not everyone agrees, then you must transport or continue working until everyone agrees. You might get into a situation where you're 60 minutes in on a VFib arrest, and you're talking about calling medical control to get orders to terminate, and someone says something feels a little off. Why don't we go a bit longer? And even if that person making the suggestion is not in charge of that scene, you still have to go a little bit longer. Everyone, all EMS personnel have to agree. All EMS personnel with our agency. Now, last but not least, there can't be a pulsatile SpO2 waveform. What does that mean? Well, anytime you have the SpO2 pleth on the patient or the pulse ox on the patient, when you're doing compressions, I know that these are compressions here because this is an impedance waveform. When you're doing compressions, you will frequently get a pulsatile waveform. When you stop CPR, it goes away. You'll see there's a lag from the time that you do the compression to the time that it reaches the fingertip because there's poor perfusion. So this correlates with this one with this one, and so forth. Anyway, the reason that we put this in there is because I heard a lecture by an EMS medical director from out west who told a story of his crews doing all of the things that they should have done. They resuscitated the patient for the minimum amount of time. The patient was in a slow PEA. They called for orders. They got permission to terminate. When they did a post-event review, they saw that the patient was in PEA, meaning that the crew could not feel a pulse, but there was a pulsatile waveform on the SpO2. And the crew did not see this. It was 3 o'clock in the morning. They had been running all day. And, honestly, more patients survive during the daytime just because we don't perform as well at night as we do during the day. But anyway, they didn't see this, and so they implemented it system-wide. And I thought that was a good lesson that we could learn from. So how do we treat trauma arrest? You'll see that in the protocol, there's a caveat for trauma arrest, specifically for penetrating trauma, but it also applies to blunt trauma. It says perform meaningful interventions. What are meaningful interventions? Well, is CPR a meaningful intervention? In fact, it's not in trauma. This might surprise some of you all that I'm saying this, because we've harped so much on high-performance CPR, staying on the chest. In trauma arrest, CPR is not going to fix the actual cause of the arrest. Therefore, you must perform interventions that are meaningful, that are going to fix the cause of the arrest, unless you're not sure it is a trauma arrest. Imagine, for an instance, that you show up for a, quote, trauma arrest that was a result of a low-speed MVC and you don't see any visible trauma. Well, in that case, you're just going to have to use good critical thinking and decide that this might not be a trauma arrest. And then your priority would be. But that doesn't mean we're not going to perform CPR. And I want to reiterate that. That does not mean we're not performing CPR if it's a trauma arrest. That just means that, I'm not concerned about your CPR fraction. I'm not concerned about your rate. I'm not even going to do a post-event review on it. This is not a case that goes into the CARES database. Even if we put it in the CARES database, they exclude it from the numbers that we report. So there are multiple meaningful interventions. What are those? What do we need to prioritize? I like to think of it as a bundle of care. In almost every type of patient you can think of, you can apply a near universal bundle of care. And this bundle is going to make it easier for you to know what to do when you're working a trauma arrest because, there's blood, the patient's messy, the calls are messy. They're found in very awkward situations, awkward places. So it's easier to think about applying the same treatment to every trauma arrest, to every blunt trauma arrest. Now, for penetrating trauma, it's a little different, but you can kind of extrapolate some of this to your penetrating trauma patient. Now, the bundle is massive hemorrhage. First and foremost, it doesn't matter what you do. If you do CPR, if you intubate and you ventilate well without controlling massive hemorrhage, it does nothing. Circulating 0% blood does nothing. You can secure the airway, you can do good CPR, but doing good CPR and circulating nothing is still nothing. It's not going to do anything. So in this instance, if you have to choose between putting a tourniquet on a patient or packing a wound or straightening a long bone, and you're choosing between that and CPR, always do that first. Fix the bleeding. Make the bleeding stop, no matter what. And this also includes pelvic binders. Pelvic binders should be part of the bundle of care for blunt trauma arrest. Doesn't matter if the pelvis is unstable or not, put a pelvic binder on. Second is airway. Secure the airway. It doesn't matter if it's soiled, suction, secure the airway. If their face is totally distorted, if they have a Lefort fracture, if they're not recognizable, then airway might be going straight to a crike. So massive hemorrhage, secure the airway. It is possible that some patients may have impact apnea. So they're apneic, and all you have to do is start ventilating that patient. And when you start ventilating that patient, their heart could start beating and they could start breathing again. So massive hemorrhage, then airway, and then tension pneumo. So we should empirically decompress both sides of the patient in blunt trauma arrest. Just do this empirically. Don't even think about it. Don't even think about if they have a pneumo or not, because at that point, it doesn't matter. Our assessment of whether or not they have a pneumo is not going to be effective. It's going to be loud. It's going to be chaotic. We could be resonating sounds from one side to another. And it could be pretty amazing. The patient could have a tension pneumo that had caused their trauma arrest, and once you relieve that tension, boom, they could get a pulse back. And resuscitate them. Give them volume. Start a humeral IO, start an IV, doesn't matter. Get access, give volume under pressure. Give 500 cc's, then give a liter, then reassess, then give more. Yes, in trauma patients, we do permissive hypotension, but those are trauma patients with a pulse. All right. In the trauma patient without a pulse, the only thing that we can do is give them volume. Right? They are too permissive hypotensive, if that's a word. Their blood pressure is not sufficient to create a pulse to perfuse any vital organs in their body. So we have to volume resuscitate them. Now, yes, we are giving acidotic fluid. We are giving fluid that contains chloride, but now we have LR, but we're diluting clotting factors. We're doing all of this stuff, but it doesn't matter. They need volume. Now, in trauma arrest, you need to determine, is it a pseudo PEA or is it a true PEA? Well, you don't necessarily have to determine that because it could be near impossible to determine that. But this is something you should think about. And I want you to think about it because it makes it easier to understand why we are prioritizing these interventions over CPR. If the patient's heart, or if you have PEA on the monitor, if you have an organized rhythm, it is entirely possible that their heart is actually beating, but they have an obstruction or they don't have enough volume to produce a pulse. There could be cardiac activity. And if you just fix whatever is causing them to be in such severe shock that you can't feel a pulse, but their heart is still beating, if you fix that, you can save them. And that is our goal in all of this. So we're going to do the things that matter and then do them again. So in trauma arrest, do those interventions that actually make a meaningful difference. Do the meaningful interventions and then reassess. So that could mean you given volume. It hasn't worked. Give more volume. It could mean that you've decompressed. It didn't work. After you reevaluated, do it again. And then make the decision. So let me go back to this. In trauma arrest, for penetrating trauma, we have to call med control to terminate. Preferably, and in most cases for penetrating trauma, you want to get them to a trauma center as soon as possible. For blunt trauma, their likelihood of surviving is significantly less than in penetrating trauma. So in those patients, we perform the meaningful interventions for the minimum required time based on the rhythm, because if it's blunt trauma and they have a PA rate greater than 40, well, we probably don't want to terminate that patient because there's a good chance that their heart could be beating. We just have to fix the obstruction or the loss of volume. And if they're in VFib, well, that's still a patient that, maybe it's blunt trauma, but there's an arrhythmogenic cause. So if their heart is beating or if they're in VFib, and we could possibly convert them from VFib to an organized rhythm, we might be able to save them. So our goal should be, in addition to performing the meaningful interventions, our goal should be to terminate and convert that VFib. So we're going to work them as long as it takes as if they were a medical arrest. And it's also possible that it was a medical arrest and the trauma was a result from that. So I hope that you all have found this useful, and I look forward to any questions that you might have. Thank you all.